Good evening. Welcome to this ILD webinar series today. Today, this webinar is basically on CTD ILD, the topic being all that you need to know. And I, Dr. Anant Mohan, I'm in the Department of Pulmonary Medicine at AIIMS, Delhi. I'm really glad to be here, and I hope that you really take back some very important pointers from this webinar today. As you can see that the scientific program has been made very nicely with some very important topics, and we'll be talking about the faculty soon. But before that, I would like to actually thank the entire organizing team. I would like to thank the Indian Chess Society, Dr. Sandeep Salvi, the president, Dr. Rajadhar, the secretary, Dr. Amita Nene, who's the chair of the academic committee here, and also would like to thank the academic partner CIPLA for being consistently supporting this whole endeavor for the past several weeks. So ILD, as you all know, is something that is really growing by leaps and bounds. The knowledge as well as the diagnostics, the therapeutics, a lot of interest is also being generated among the respiratory physicians. But in spite of all that, there is still that is unknown. There is still some gray area. There is still some confusion over many aspects, and that is why this repeated learning and repeated teaching is so important. Today, uh, we have two extremely good talks, and after that, we have some excellent faculty as part of a panel, and they'll try to take your questions as well as some other important questions related to CTD ILD. Try to cover the whole topic in as comprehensive manner, but as crisp a manner as possible over the next 1 to 1.5 hours or so. So, without much ado, I think I'll immediately start off. I'll introduce the first speaker. The first speaker is Dr. Bhavin Jankharia, and again to the respiratory fraternity, he needs no introduction whatsoever because he's a very senior and experienced thoracic radiologist and an eminent teacher, a very avid teacher. In fact, he's part of so many international and national bodies, part of most of our all of our conferences, and he's written so many books, monologues related to thoracic radiology, and he's, I think, the one of the best people to be speaking on this. So he'll be speaking on the imaging in CTD ILD, CTD related ILD, because this actually is the most important modality. CT is the most important modality to diagnose. So he'll give us an overview of how to kind of recognize CTD related ILDs.
Hi, welcome to this lecture on connective tissue disease ILDs, and I'd like to thank ICS and Simpler for asking me or giving me the opportunity to do this talk. So connective tissue diseases are a heterogeneous group of systemic inflammatory disorders, and they encompass these entities: RA, scleroderma, Sjogren, SLE, PMDM, and antisynthetase, and mixed connective tissue disease. IPAF is an entity that was created essentially for research purposes, and I'll spend about a minute on that later on. The connective tissue diseases can involve all of these structures in the chest, but today we will be focusing only on the lungs. We will talk about the protocol for scanning, which I have discussed before, different patterns of CTD ILD, CT signs suggesting underlying ILD, the individual connective tissue diseases, and as I said, a couple of minutes on IPAF. The protocol for scanning, good quality study is an absolute must if we want to make a good diagnosis. This is the protocol: volume inspiratory 1 millimeter scans, expiratory scans, and volume prone 1 millimeter scans. The different patterns that we can see are listed here. The UIP pattern consists of subpleural basal predominance of honeycombing and traction bronchiectasis with nothing else. And so this is a common pattern seen in multiple connective tissue diseases. This patient has scleroderma and also has esophageal dilatation. Then we have the NSIP pattern, where we often get subpleural sparing, spatial and temporal homogeneity, and absence of honeycombing, you may get traction bronchiectasis. There can be a cellular and a fibrotic component, and I discussed NSIP in detail in the last lecture in March. The third pattern is the organizing pneumonia pattern, where we get subpleural or peribronchovascular areas of consolidation and admixed ground glass. We've seen this pattern commonly during COVID, but it also occurs with connective tissue diseases, as in this patient with RA. Here's another patient who has a fibrotic OP pattern, peribronchovascular areas, but with traction bronchiectasis, seen in this patient with mixed connective tissue disease. Then we have cystic disease, where we see perivascular cysts as part of Sjogren's disease. Lymphocytic or lymphoid interstitial pneumonia also has perivascular cysts. But remember that this is not an interstitial lung disease until you see an ILD. So these are just the perivascular cysts of Sjogren's. And if you see an associated ILD, then that becomes LIP. Now, all this is fine. But when do we suspect an underlying connective tissue disease? When we are seeing CT scans of interstitial lung disease? And that's important because not all patients present initially with full-blown CTD features. And so we actually suggest on the CT that the patient may have CTD, and then further tests are carried out to confirm the diagnosis or not. And here are all of those signs that I'll be talking about. Exuberant honeycombing is when we have more than 70% of a specific lobe involved with honeycombing. So you're seeing subpleural basal predominant and lots of honeycombing and cystic change in this patient with RA UIP. So when you see this, you should suspect connective tissue disease. The second is heterogeneous lung destruction. So along with the honeycombing, there's extensive cystic change involving the lung parenchyma, usually bilaterally. In this case, it's the left lower lobe. And this is described in patients usually of RA and SLE, but may be seen with any connective tissue disease. The anterior upper lobe sign is exuberant honeycombing in the non-dependent upper lobes or in the anterior segments of the upper lobes. Now, this sign, if seen, is a very specific sign of connective tissue disease. You rarely get it with any other condition. And this patient has rheumatoid arthritis, but we commonly see it with scleroderma and SLE as well. Another recently described sign is island-like fibrosis, where the intervening lung parenchyma is normal, but we get these wedge-shaped areas of honeycombing, traction bronchiectasis, and reticular opacities. These typically occur in the CTDs that are also vasculopathies, and so are commonly seen with SLE and scleroderma. The four corners sign is typically seen when we have islands of fibrosis occurring in the four corners. So anterosuperior and posterior-superior. And this is better appreciated, therefore, on the sagittal and the coronal images. And you can see that the intervening lung is quite normal. And this patient has scleroderma. The sign we use every day in practice is the straight edge sign, which is seen on the coronal and the sagittal images, where there's a very sharp demarcation between the abnormal and the normal lung. And when we see this sharp demarcation, it gives us a sense that the patient may have connective tissue disease. So every patient who comes with CTD, we look at the images in sagittal and coronal at the same time. And if we see a straight edge, then I will write down that please aggressively rule out connective tissue disease. And see this patient with UIP, IPF, there's an undulating margin as against a patient with CTD ILD who has a straight edge here. The last sign is low attenuation areas. This is specific for scleroderma. You see this patient has a fibrotic NSIP pattern. We have subpleural sparing here. Now, within these reticular opacities, you see these low attenuation areas. This is supposed to again represent a vasculopathy. You might probably see it in SLE as well, but it is described as a sign of scleroderma. So these are all the different signs that when we see on a CT scan suggest an underlying connective tissue disease. Then let's look at the individual CTD. So we have RA, where UIP is more common than NSIP, which has the same commonality or incidence as OP, and these are more common than LIP. So I'm just going to show this for the rest, and I will not really describe this. Smoking increases the incidence of RA-ILD and is an adverse prognostic factor. And if you have UIP and extensive disease, then that's adverse prognosis. So here's a patient with RA, smoker. You can see centrilobular emphysema, paraseptal emphysema with a probable UIP pattern, and this is very classic uh, CPFE in a patient with RA. This I had already shown. You have an anterior upper lobe sign with exuberant honeycombing in the non-dependent segments. And here is a patient with exuberant honeycombing and heterogeneous lung destruction in this patient known to have RA. This is a patient with RA presenting with an organizing pneumonia pattern. And this patient has RA with lymphoid interstitial pneumonia, with perivascular cysts, ground glass, reticular opacities, and a mix of multiple findings that suggest this pattern. In RA, we can get other findings. We can get airway diseases, follicular bronchiolitis, necrobiotic nodules, and drug-related complications. This is a patient who has of RA with extensive peribronchial thickening, distal branching, centrilobular opacities, and nodules, and this suggests follicular bronchiolitis. This is a patient of RA who has these necrotic lung nodules, which I biopsied, and this was consistent with necrobiotic nodules. We then come to scleroderma, where NSIP is commoner than UIP. If you have UIP, that's a worse prognosis. PH is a common accompaniment and also has a worse prognosis. You do try and differentiate cellular from fibrotic NSIP, though it is not always possible except retrospectively on follow-up. And you may see esophageal dilatation as well. So this is a very early scleroderma ILD where we see just subtle reticular opacities, but which are confirmed to be real on prone images. This is more advanced disease where we see subpleural sparing and spatial and temporal homogeneity. So there is an NSIP pattern, but you see these peribronchovascular lesions that also suggest an associated organizing pneumonia pattern. And very often in these patients, we see mixed patterns. So you have a mixed NSIP OP pattern here. I'd already shown this scleroderma with the UIP pattern. And in scleroderma, follow-up happens very commonly at 1 year or 2 year intervals. And here is a patient who has improved 13 months apart, and here is a patient who has worsened 15 months apart. We also see complications in these patients, and here is a patient who developed tuberculosis in the left apex, which then regressed 4 years later, while the NSIP pattern remained unchanged over those 4 years. SLE is a more wet disease where we get pleural and pericardial effusion, lupus pneumonias. NSIP is more common, but we can also get diffuse alveolar damage. So here is a patient with acute SLE, pericardial and pleural effusion, and you get these areas of consolidation showing an organizing pneumonia pattern but are consistent with lupus pneumonia. And here you can see that the patient just has these subtle areas of ground glass representing lupus pneumonitis in another patient. This patient over 14 years has shown a UIP-like pattern, but what you're predominantly seeing is traction bronchiectasis with extensive cystic change and heterogeneous lung destruction. Whereas here is a 50-year-old with NSIP who shows a classic NSIP pattern. You have non-dependent involvement here with reticular opacities and traction bronchiectasis. This patient also has heterogeneous lung destruction. I showed this image earlier as well. And here you have island-like fibrosis because SLE is a vasculopathy. And you can see these focal areas, likely because of focal infarction and vascular changes causing these areas of fibrosis. Patients with SLE can present with diffuse alveolar damage. And here we see diffuse alveolar hemorrhage with extensive areas of ground glass septal thickening, almost a crazy paving pattern with bilateral pleural effusions and dropping hemoglobin. Here's another patient with extensive lung disease, and this would just qualify as acute lung injury. We then have Sjogren's syndrome, where it's more common in women as compared to men. You can have primary and secondary Sjogren's. NSIP is common, though LIP is considered a typical ILD of Sjogren's. NSIP is still the commoner entity, and you can also get airway diseases with a significant increased risk of lymphoma. So here is a classic Sjogren's NSIP. We have spatial temporal homogeneity, traction bronchiectasis, no honeycombing. And this I'd shown earlier, where we're seeing perivascular cysts of Sjogren's disease, but there is no LIP at this point in time. This is another patient who presented with an organizing pneumonia pattern in 21. Actually had biopsied this as well. There was progression over 3 years. At this point, I thought perhaps the patient had an invasive mucinous adenocarcinoma. Turned out to be an OP pattern. Then the patient turned out to have Sjogren's. And then when the patient was put on steroids, you can see significant improvement on the radiographs. PMDM and the antisynthetase syndromes present with different forms of ILD. NSIP is the commonest. They also have aspiration syndromes. And these are two different patients, both of whom show typical NSIP patterns. Here you have a patient with antisynthetase syndrome who shows this proximal traction bronchiectasis in the middle lobe, which is not just common for antisynthetase, but occurs again with connective tissue diseases. And here we see traction bronchiectasis without honeycombing, telling us that this is a fibrotic NSIP pattern. We have mixed connective tissue disease. Again, women are more involved, or occurs more in women than men. And you see the rest of the findings here. And this was a proven mixed connective tissue disease, has a fibrosing, organizing pneumonia pattern. And another patient with MCTD who has an NSIP pattern here, which has improved over a year. So to summarize, these are the 6 conditions, and these are the different patterns that we get here. And we should be aware of what is common in which connective tissue disease. So if you have a patient known to have scleroderma or Sjogren's or SLEs, you will look for those patterns. But if you have a patient presenting as an unknown, then we would suspect CTD based on the signs that I mentioned earlier, and then try and figure out perhaps which CTD this might be. IPAF is a very confusing term. It was created so that everybody who does research on CTD ILDs would use the same criteria to identify those patients. And it was assumed that people would work together. What has happened is that while at the research level, this is to some extent happening, it is somehow being used as a clinical term, which was never the intention in the first place. So today, the idea in the last about 16, 17 minutes was to talk about different patterns, the CT signs suggesting ILD, the individual CTDs, and a little bit on IPAF. This is the QR code to my link tree, which links all the posts that I do on a regular basis at ctchestreview.com, ctbiopsy.com, etc. That's the book at Amazon. Thank you so much for listening to me, and have a great
Thank you very much, Dr. Bhavin. And again, as usual, a very, very clear, crisp, and concise presentation. He has told all the common ILDs, the common patterns of ILDs in the CT, various common CTDs for us. So covered SLE, Sjogren's, scleroderma, RA, polymyositis. So it is important for us to at least know which are the important patterns and how are they recognized when we see a HRCT. At least we should be able to have some idea of the gross appearance of the type of ILD that we are seeing. And I think that he has shown very nicely by means of very high resolution pictorials, graphics, CT images, which I'm sure is going to be very useful to especially to all, especially postgraduates. and also some very key points. For example, NSIP is most common in which type of CTD, UIP is most common in which type of CTD, very common postgraduate level questions also, which will be very helpful for them. So with this, I think, should we move on to the next talk? Yeah. So basically, the next talk will be taken by Dr. Praveen Valsalan, and as you can see, his CV is there. He's the lead consultant, clinical and interventional pulmonologist at the Aster Med City in Kochi, holding several important professional positions, the examiner and teacher of various prestigious examinations as well. And he has been publishing also in journals and books and book chapters, and has won several awards and various achievements. So I think a very fine young respiratory physician, and he will be talking to us on the CTD ILD's conundrum from the pulmonary perspective, or from the pulmonologist perspective. So, Dr. Praveen, you may please start.
Thank you, sir. Thank you for those kind words of introduction. So, let's share my slides. I hope the slide is visible. Yeah.
Yes, it's all right.
Yeah. So a very warm good afternoon, good evening to one and all. It's indeed a great pleasure and privilege for me to stand in front of in front of the esteemed audience who's gathered in this webinar. And I specifically thank the organizing team of the IAB, Dr. Amita, and the whole team, the SIPLA, and everybody for giving me the opportunity for me to be here. So I'll be talking on this CTD ILD from a pulmonologist point of view. So I'll touch upon the scenario and introduction, the clinical approach to CTD ILD treatment and follow-up, primarily looking at the ACR guidelines, which has come in the last year, and some trials. So this is a slightly longer talk, so I'll make it a little bit faster also to finish it. And most of these, I think, probably we can even deal in the later part of the questionnaire session also. We'll touch upon two cases. One is a 48-year-old gentleman with an exertion breathlessness of 8 years with on and off cough, small joint pains, and was told to have a rheumatoid arthritis on traditional medication. On examination, he had a clubbing, bilateral and inspiratory crackles with a normal saturation. These two was a 63-year-old female diabetic, exertion dyspnea for 4 years, and it was increased for the past 1 month to a grade 4 MMRC, presented to ED. Initially, she had a bilateral arthralgia, she was on Ayurvedic medication again, and this currently the small joint pains and stiffness has included along with the proximal weakness of the muscles. On examination, she had a frontal balding, heliotrope rash around the eyes, erythematous rash around the neck, and her saturation was 80% in the room air. So this is the two contrasting scenarios that we might see when we are looking at this whole conundrum of this CTD ILD. So it's basically a spectrum. Now, one end we have this very stable patient, and the other end we have this extremely sick patients who requires an urgent intervention. So as I said, we have, as sir has already mentioned, we have this whole CTD ILDs and whole this radiological as well as this pathological part of this ILDs in what we see in the CT as well as in the histopathology. And most of the CTD, it's not just the interstitial that is involved, as sir has already mentioned. There are a lot of pulmonary manifestations also. Like, for example, systemic sclerosis has a lot of vascular manifestation other than the parenchymal thing. Similarly, the rheumatoid arthritis has a rheumatoid arthritis ILD has rheumatoid arthritis has parenchymal manifestation as well as the airway involvement and pleural involvement. Sjogren's also has ILD and airway involvement. Mixed connective tissue has the parenchymal as well as the vascular involvement. Polymyositis has a primary parenchymal involvement, interstitial involvement. SLE has a lot of pleural as well as a vascular involvement, as well as it can present with a DAH. So all these are various manifestations. So unless we know that if these patient presents like this, then we need to correlate it with the specific, the phenotype that we see in this patient and come to a diagnosis. If you see the whole clinical landscape of this, the CTD ILD. So one is that the ILD is an established CTD, there is no doubt. So, but then again, the question is whether the ILD is CTD ILD, CTD associated or not. But then we have this idiopathic ILD wherein we need to look for and watch out for an occult CTD in that. And there's other entity where there is an idiopathic ILD, and the question is whether it CTD related or not. Most patients who has an CTD, who has an ILD, CTD ILD, they are diagnosed as CTD prior to diagnosing an ILD. But there is a big subset of patients whom ILD is the presenting feature. So, as I mentioned earlier, the reasons are various. So one of it is that there is many of these patients has a subclinical disease, as I mentioned in the case 2, but these patients go on for a long time because of the subclinical disease, and they think it's because of they overlook all these and attribute to various causes, like for example fatigue and dyspnea on exertion due to deconditioning. They are not walking around, and a lot of other reasons that they think about. Dyspnea, which is again masked because of the patient is not walking. The cough, they think that it could be because the medication side effects, etc., etc. So these symptoms are unlikely to be a differentiating symptoms for a CTD ILD from other types of ILD. So we need to probe for the extrapulmonary symptoms in every patient whom we suspect a CTD ILD. And of course, PFT is a must. It shows a restrictive ventilatory defect with a reduced total lung capacity, reduced FVC, reduced FE1 by FVC ratio, raised FE1 by FVC ratio, and a reduced DLCO. Occasionally, the FVC may be normal in mild or mixed, or with patient with a coexisting emphysema. And there could be a mismatched reduction of DLCO if there is a pulmonary hypertension or emphysema, or sometimes it could be increased if there is a DAH. So, said and done, the diagnostic investigation of choice for an ILD, we all know it's an HRCT, and Sir has already elaborated on that. So, I won't be going into it. So, there's a good correlation between the extent of ILD as assessed by HRCT, as assessed by FPC and DLCO. And if you do even for that matter, a lung biopsy, there is a good correlation with what they see in the lung biopsy with the HRCT. So, that is the reason why an HRCT is the gold standard. And of course, we can see the other areas of the lung or any other extrapulmonary structures that is involved. So what are the CTD signs? There is a lot of signs, but then, when we have a constellation of signs, we need to look at what the disease is. So the constellation of the signs, looking at that constellation of the syndrome, we can come to a reasonable conclusion what the disease, what the connective tissue disease could be. Like for example, patient with a Raynaud's phenomenon, sclerodactyly, digital ulcers, telangiectasias, and skin involvement. The likely chance is that there's a systemic sclerosis with a polyarthritis, polyarticular synovitis, rheumatoid skin nodules, rheumatoid arthritis. Proximal muscle weakness, symmetrical muscle weakness, Grotton's signs and papules and Scholl sign, like in our patient, which I mentioned earlier, it's an inflammatory myopathies. Then photosensitive rash or malar rash with an oral ulcers, alopecia, serositis, SLE, Sika syndrome, enlarged parotid Sjogren's, and swollen hand synovitis, myositis, atherosclerosis, and Raynaud's. It could be an MCTD. What are the biomarkers that we need to look at it? So any patient whom we have diagnosis and ILD, if they have an, if there is an, if they are suspicious of an connective tissue disease, they should undergo the biomarkers, the serum biomarkers, that is the autoantibody associations. So we have this huge list. So any patient coming with this sort of features, we do them, and all these patients will undergo an rheumatoid arthritis, RF factor, anti-CCP. If there is a low index of suspicion, we can go ahead with an ANA by immunofluorescence, or otherwise an ANA profile and myositis profile. And if we have suspicion of vasculitis, do an anti-MP or PR3. So these are the various autoantibodies that is associated with this. Like say a patient has an anti-centromere, anti-SCL70, and anti-RNA polymerase, systemic sclerosis, RF factor anti-CCPs, rheumatoid arthritis, myositis specific antibodies and myositis associated antibodies. It's an inflammatory myositis. ANA anti-DS, DNA anti-Smith, then more likely to be an SLE. ANA RO60, RO60, RO52, then it's a Sjogren's. Then mixed connective tissues, ANA and anti-RMP. So these antibodies we must know, and otherwise we might miss the diagnosis. The other thing is the need for whether there is any need for a lung biopsy or a BAL. So, in an established connective tissue disease, interstitial lung disease, there is no role for of whatsoever for a lung biopsy. So that's no doubt about it. What about the BAL? BAL is only to rule out any other processes, like if a patient who is intubated and wants to start on an immunosuppression immediately, if their infectious markers are raised and if the patient's condition allows, then probably you can do a BAL to rule out an infection. Second is to rule out a DAH. So these are probably the two main conditions to that BAL is actually required. If there is an uncertain HRCT, then probably, and like say, for example, a fibrotic NSIP, then to differentiate it from a fibrotic HP, probably and lung biopsy might be can be done. In surgical lung biopsy used to be the goal, but now we have a lot of evidence for a bronchoscopic cryobiopsy that it is equally useful. So said and done, in an established CTD ILD, there is no long role for lung biopsy. So need for biopsy need to be tailored on the patient characteristics, multidisciplinary consideration, and local resources. So this is the cold eye study, which clearly showed that there is a high level of agreement between the cryo lung biopsy and surgical lung biopsy for both histopathological interpretation and MDD diagnosis. And this is the meta-analysis which showed that there is a good correlation between the pooled diagnostic yield and the sensitivity and specificity. And there's a mild reduction in cryobiopsy versus that of the BAL, but complications are much less for the cryobiopsy. So the former could be considered as an alternative in the evaluation of the patients with the diffuse perineal lung disease. If you see a patient with an ILD and if you're suspecting the patient has an connective tissue disease, then after history and examination, look at the biomarkers which I mentioned earlier. Then we need to look at characterize the patient morphologically as well as physiologically. For morphologically, we need to do an HRCT. Physiologically, we need to do the lung function, the 6-minute walk test, and an echocardiogram. And of course, we need to rule out other causes. It's better to show it to the rheumatologist so that they can have a good assessment of the rheumatological part. Then followed by a multidisciplinary team, including the pulmonologist, the rheumatologist, the radiologist, and then come to a consensus of a diagnosis of CTD ILD. So if not, then it has to be dealt in that way. But if yes, to see whether the patient has a stable or a progressive connective tissue disease. A stable tissue disease, probably nothing else might be required. Only the non-pharmacological management, including the rehabilitation, psychosocial control of the patient, the oxygen requirement, the nutrition, and managing the other risk factors and comorbidities, including the GERD, smoking cessation, etc. But if the patient has a progressive disease, then pharmacological management is advised, which will be coming later. And then this patient has to be monitored with lung function testing. So, on histopathology. Histopathology, as I mentioned earlier, there is a good correlation with the HRCT finding, but there could be a lot of overlap. As we see in an HRCT itself, there could be a lot of overlap between the major patterns of the ILD. But said and done, NSIP is more commonly generally seen in a UIP in the setting than in a UIP in a setting of CTD ILD, which Dr. Bhavin has already mentioned. In NSIP, in pathology, there could be a cellular NSIP or a fibrotic NSIP or a combination of both. If there is an OP pattern in biopsy, think of an myositis, and if there is a diffuse alveolar damage, which predicts a bad prognosis. There are some histological criteria to differentiate an connective tissue disease UIP from an IPF UIP by looking at the fibroblastic foci, the lymphoid aggregates, and the presence of an NSIP as parameters. So if a patient has in a histopathology, there is a fewer fibroblast and a smaller fibroblastic foci, then it's more favors the CTD UIP. Similarly, RA UIP has a much more larger lymphoid aggregates in germinal centers as opposed to that of an IPF. If there is a coexistence of the UIP and NSIP, and there is a histopathological variability, like one lobe has an UIP pattern, other lobe has an NSIP pattern, then think of again an connective tissue disease. You need to look at if the patient has an out of proportion dyspnea, look for the other system involvement. Very, very important. Like for example, a patient who pulmonary hypertension, especially more commonly seen in the limited variant of the scleroderma, muscle weakness seen in the myositis profile. So all these leads to an out of proportion dyspnea, cardiac involvement in the form of obstructive cardiomyopathy or direct pericardial or myocardial involvement, like in, for example, in rheumatoid arthritis or SLE, etc. So all these leads to an out of proportion dyspnea. If you see that, we need to look for the causes of it. So, sir has already mentioned about an interstitial pneumonia with autoimmune features, wherein these patients has an underlying autoimmune process but does not meet an established criteria for a CTD ILD. So, the features are there is an a priori requirement of an ILD pattern and a thorough clinical evaluation to rule out the other causes of known causes of interstitial pneumonias, and it should not meet the defined CTD. Followed which they should have they should be classified according to the three domains: clinical, serological, and morphological domain. So to say that the patient is an IPF, it should have all the three a priori requirements, including the interstitial pneumonia by HRCT and thorough clinical evaluation, and not meeting the criteria for CTD ILD, and at least one feature from at least two of the above domains: clinical, serological, or morphological. So clinical domain, we have already mentioned all the clinical features of the CTD ILD. The serological domain, again, we have mentioned various antibodies that is there. And the third thing is the morphological domain. So we need to have a suggestive pattern by HRCT or histopathology pattern or a multi-compartment involvement, like pleural pericardial effusion or an airway disease or a pulmonary vascular disease. So what is the current approach to treatment for a CTD ILD for any pattern? The basic thing is always an inflammatory immunosuppressive medication. So we'll just see that based on the ACR guidelines later, followed by an anti-fibrotic if required. We'll see that pulmonary rehabilitation and lung transplantation. So the ACR guidelines is very clear on how to screen the ILD if the patient has an increased risk for ILD in those patients with a connective tissue disease. Look for the signs and symptoms clinically, and then do a HRCT followed by a PFT. That includes the spirometry, the lung volumes, and DLCO. So if the ILD is diagnosed, then the PFT has to be repeated. In a myopathy, it is every 3 to 6 months for the first year. In a systemic sclerosis, 3 to 6 months for the first year. And others, it is 3 to 12 months for the first year, and then less frequently once stable. Ambulatory desaturation testing can be done every 3 to 12 months. HRCT as and when required. For a screening test which are recommended against is no need for chest radiography, no need for 6-minute walk test. I'm talking of a screening test. No need for ambulatory desaturation testing. It can be used if the patient is unable to perform an PFT. No need for bronchoscopy except to rule out an infection, sarcoidosis, alveolar hemorrhage, or lymphoma. Surgical lung biopsy is only to rule out a malignancy. Monitoring test which is recommended against is, again, no need for a chest radiography. 6-minute walk test is not required if the patient is able to perform a PFT. Bronchoscopy, again, not required unless there is an evidence of infection or alveolar hemorrhage. What are the treatment options? So we know with the available trials, there is a very strong recommendation against glucocorticoids for systemic sclerosis. So there is no need for a we are talking of talking as an initial treatment option for a stable patient with a systemic sclerosis or for stable CTD ILD. All the other CTD ILD, including myositis, MCTD, and rheumatoid and Sjogren's, they can be started with a short-term glucocorticoids along with the immunosuppressants. So the best immunosuppressants across the group is mycophenolate, and the other ones, including the tocilizumab, the rituximab, the cyclophosphamide, the calcineurin inhibitors, the JAK2, the azathioprine, etc., etc. There is a conditional recommendation for nintedanib in SSC ILD, but in other ILDs, it is nintedanib. There is a recommendation against nintedanib as a first-line option. And myopathy, the myositis, it is JAK inhibitors or the calcineurin inhibitors. And in those patients receiving mycophenolate without an evidence of progression, there is no need for adding a nintedanib or a pirfenidone. And in systemic sclerosis ILD and MCTD ILD, tocilizumab can be used as a first-line management. Then what happens? This is the first line management. Now, what happens if the patient progresses? People with progression of ILD on the first ILD therapy, they probably there can be an add-on or switch therapy. So across the group, there is a strong recommendation against glucocorticoids as a long-term therapy. But all the other drugs that we have already mentioned can be added to it. And the last and but not the least is the referral for a lung transplant evaluation at appropriate time. And if it is a rapidly progressing ILD, then look for whether it is a severe disease or a high suspicion for an MAD5, MDA5. That is like an myopathic dermatomyositis. If it is yes, then start them on an IV glucocorticoids with 2 additional therapies from rituximab, cyclo, IVIG, mycophenolate, calcineurin inhibitors, and JAK2. So if the patient is quite sick, then we generally start them on an IV glucocorticoids with an IVIG and a rituximab or a cyclophosphamide with a rituximab. If the patient does not have a severe disease, stable enough, but rapidly progressing, then IV glucocorticoids with 1 or 2 of the additional therapies, including rituximab, cyclo, IVIG, mycophenolate, and calcineurin and JAK2. So in these patients, beyond a point, consider early lung referral, transplant referral. So in all the patients, nintedanib is except for systemic sclerosis, there is a condition recommendation not to use nintedanib. For an SSC ILD, there is a condition recommendation to use nintedanib as a first-line ILD treatment option. In RA ILD, they were not able to come to a consensus. So coming to the antifibrotics in ILD, there are a lot of trials, including the Lotus trial, the SLS2 trial, the Trial 1 trial, etc., the Trial 1 trial, etc., etc., assessing various antifibrotics in ILD. These are all the trials. I'll just touch upon trials. One is the Senesis trial, because that's the one which cemented the role of nintedanib in SSC ILD. 576 patients, and what we've seen is the change in FEV1 was, as you can see, is significant in those patients who is on nintedanib rather than on placebo. So, and even the annual decline in FVC. So, even though the annual decline in FVC, because these patients were already on the immunosuppressant, so there was the decline in, even though the decline in the FVC was absolute decline in FVC was significant, the relative decline in the p value was not very significant at that point of time. Then this is from the subgroup analysis of the inbuilt trial, where they looked into the autoimmune group of disorders. And what was found is a rate of decline in FVC over 1 year, that is disease-wise, as well as the fibrotic pattern-wise. Both were favoring the use of nintedanib in these patients. The take-home message is the CTD ILD contributes significantly to the morbidity and mortality in patients with autoimmune disease. A keen observation is required to diagnose CTD when we confront a patient with ILD. Compared with idiopathic interstitial pneumonias, CTD is associated with a more favorable prognosis. A multidisciplinary approach is the gold standard. So we need to have, if these patients have an ILD, always go ahead with an MDD. Outside of the systemic sclerosis literature, there is a little data and few guidelines to assist the clinician in treating and monitoring CTD ILD, except for the last ACR guidelines which came. And some patients with CTD ILD will be treated with immunosuppressive therapy directed towards their non-pulmonary systemic manifestation, because that is probably sometimes one thing that can improve their quality of the life rather than the ILD part alone, because ILD part may not reverse at that point of time. And trials with antifibrotics are going on, and we require a well-designed, adequately powered trials. So with this, I invite all of you for the BronchoCon 2024. I'm Dr. Praveen. I'm the workshop chair for the BronchoCon 2024 to be held at Cochin from 24, 25, and 26 at Le Meridian, Cochin. So I welcome you all for that. Please participate. I'm sure we can give you a very good academic extravaganza. Thank you.
Thank you very much, Dr. Praveen, for an excellent overview of CTD ILD from our respiratory perspective. Exactly the way that one would like to do when we get a patient in the OPD, then exactly how to proceed step by step, starting off with a history, a focused history, and then trying to expand to try and find out all the other details regarding if there is any CTD. If so, then what type of CTD, whatever we can get. And then how to the clinical approach, the physical findings, then how to approach from these parametries, all the non-invasive tests, of course, the role of HRCT and other things you have highlighted, and also what not to be done is also be told, because at in every situation, one need not do everything. When not to do biopsies, when to do biopsies. So the indications of biopsy is now uh, reasonably settled in a way, that in uncertain types, wherever you are in a dilemma, then you do it. Role of lavage is also useful in some settings. For example, if you do a lymphocyte count in suspected HP, yes. If you are suspecting PAP, you may get milky fluid. Suspecting infections like PCP or in diffuse alveolar hemorrhage. So these are the settings where a bronchoalveolar lavage would be very, very, very helpful. So, and then proceeding on to the various therapeutic options that we have. Also, you have touched upon the role of cryo TBLB versus surgical lung biopsy. Also important from our perspective. And then the various therapeutic options, I think, have been very nicely touched upon. So what is interesting is again that in most of the CTD ILDs, steroids have a role, kind of short to medium term, but where not to give it is also been told, and that is important. So, and also what to do when the disease progresses. I'm sure many of these questions will also be covered in the panel discussion subsequently, depending upon the questions coming. So thank you, Dr. Praveen. I think we'll move on to the panel discussion now without any
Yes.
more delay. And I would like to invite all the panelists, and I'd like to introduce all of them to you. And we have here a very, very eminent panels. And I'll start off with Dr. Amita Athavalem, and she's well known to all of you. She is currently professor and head of the Department of Pulmonary Medicine at SAIT GS Medical College and KEM in Mumbai. And she, as you can see her, she has held many prestigious professional positions in the past few years. Many awards and achievements have to her credit, and she has written books, chapters, and several journal articles as well. So welcome, Dr. Amita. Next, I'll invite Dr. Pratibha Gogia. Dr. Pratibha is currently heading the Department of Respiratory Medicine and IP at Venkateshwar Hospital in Dwarka, New Delhi, with a keen interest in airway diseases and IP. Has obtained ERS fellowships from UK, the Royal Brompton. Again, a keen publisher, has been publishing and presenting and sharing experiences at various conferences, and also has delivered orations with for her contributions to IP and other fields of respiratory medicine. So, welcome, Dr. Pratibha, to the panel. Next, I would like to invite and introduce Dr. Debraj Jash, and he is head of the pulmonary department at Manipal Emory and Medica in Kolkata. He's been awarded with ERS gold and silver sponsorships, and in fact 3 years earlier, and also Apollo Young Clinician Award. Keen interest in pulmonary critical care, airway diseases, and IP. Several publications, and also on the GMA editorial committee, and has been publishing and helping in research as well. So, welcome, Dr. Debraj. Next, I'll introduce Dr. Deepak Muthreja. Dr. Deepak is heading the Pulmonary Critical Care and Sleep Medicine Department at basically in the Nagpur at the AOI and the Nangia Hospital, a specialty hospital in Nagpur. And again, welcome, Dr. Deepak, and we'll be hearing more from you as well. And also, I'd like to invite Dr. Praveen, who has just spoken the lecture, to also be part of the panel, so that we can basically start and kind of share and interact also and share experiences. So without any ado, I'll start now. Basically, it will be a kind of take through the spectrum and the journey of a CTD ILD patient. So we'll try and cover most of the important questions that come our way. First question I'll address to Dr. Amita. So Dr. Amita, starting off, from the basics, history taking is obviously the basics, and I think we should never kind of stop overemphasizing the importance of history, not just for CTD, but for any disease for that matter. So, what do you think will be the important pointers, important things to be asked in the history, specifically towards CTD ILD?
So true. So, having checked the cardinal symptoms, cardinal respiratory symptoms with respect to CTD ILD, one can have a quick checklist as we teach. As the patient walks in, while you have a look at him, you would notice the phenotypic features. And while you notice the phenotypic features, that is the time You could ask him regarding the arthralgias, the joint swellings, which would be for rheumatoid arthritis. If you see an early graying of hair, that in itself is an important clinical sign, which we now know is a representation of telomere shortening. One would also notice other features and ask the patient regarding intolerance to cold, where he gets a Raynaud's, and also on exposure to sun, whether there are any skin changes. Probably a quick question on whether he has visited a skin specialist in itself reveals a lot of things, as so many times the salt and pepper appearance, which you may get in scleroderma, the paniculitis, which one may see, all that gets noticed, or there might be a consultation long ago. But if asked a direct question, you get to know that much earlier on history. So, hair loss is another important aspect. So, that's about the phenotypic features. And when we go into the details of the history, again, dysphagia, the GI symptoms would include dysphagia and the symptoms suggestive of reflux. Along with that, one would ask for mouth ulcers, gritty sensation in the eyes, which would be for Sjogren's, and tightening of skin. And most importantly, what I would want to share is dermatomyositis and myositis. This is something, once we have started doing the markers for myositis, we've started realizing the very subtle symptoms or clinical presentation of myositis. Two of our patients came with only symptom of, while they were talking on phone, on the other side, the person noticed that they were short of breath and there was no other symptom. Clinical examination, when they came in, was virtually all okay. While we did their MIP, MEP, and then sent the profile, we got the results. So, in myositis, another important history one which one would ask is whether there is a history of intermittent, frequent episodes of fever, which can be just a 1 day fever with some muscle symptoms, some muscle aches, generalized fatigue. And that's where we are going to be going into the depth, and then maybe a pickup can be early. So many times they come for just a LRTI or a upper respiratory infection, and then when you go into the depth or maybe check out on functions, we get to pick them up. So much about the phenotypic features and the history points which one may include as a checklist. Thank you.
Okay. Thank you very much. I think again very nicely summed up that one starts the history taking from the time the patient actually walks into your clinic. I would say the very appearance of the patient may be highly suggestive. Scleroderma, they have some typical facial appearances. They may be Cushingoid. If they are Cushingoid, you
Oh,
will
yeah.
know that they have been taken chronic steroids. Then immediately you will start looking at why they were taking steroids. They may be walking with a stiff leg or a stiff, gait. You'll immediately start thinking of rheumatological problems. So all these small things should be looked at, of course. And then, of course, all the history that Dr. Amita has talked about. So I'll come to Dr. Pratibha now. So, Dr. Pratibha, after this broad overview of history taking, if we talk a little bit about specific CTDs, RA is rheumatoid arthritis is the one of the most common CTDs that we encounter. So, what would be a typical history that one would like to ask in a patient to elicit and to confirm that yes, he's most likely or she's most likely to have RA? And then, what would be the important signs that we would look at in the clinical examination? Yeah, you are muted, Dr. Pratibha.
Right. I'm unmuted. So sorry for the technical thing, but RA is the most common CTD we encountered. And my bet when diagnosing RA is early morning joint stiffness. So, which is an essential criteria of American Society of Rheumatology and ULAR classification or signs of uh, RA. So whenever we are inquiring, then we asked about early morning stiffness. It should be more than 30 minutes, but previous classification says 60 minutes. But even if patient comes up with that, it takes her 30 minutes to get back her joints to normal. functioning, it is suggestive of rheumatoid arthritis. And you can, when you examine the patient, you can look for nodules, but before that, you can look for joint swelling. It's mostly the proximal interphalangeal joints which are involved, but that's not a rule. Even the large joints like shoulder joints or elbow joints, sometimes they can also be involved. Then once we are suspecting RA, then we should order some of the blood tests like CRP, ESR, and to be more specific, RA factor and anti-CCP. So this is the way we deal in a patient of RA. But the base beauty of RA and ILD is that sometimes lung involvement precedes the joint involvement. So we have seen such cases where, initially we have lung involvement and later on the patient developed florid signs and symptoms of rheumatoid arthritis. So it can proceed almost 3 to 4 months before the joint involvement.
Correct. So I think again some very important points there. The history of early morning stiffness, very important and very specific actually. So again, in a bit of a hurry, one should not just ask blindly, just, do you have joint pains? And they will say, yes, we have joint pains. And you say, okay, then it is RA. That is not true. And immediately one goes and order rheumatoid factor. That is not true. The joint pains of RA have a distinct this thing specificity to that, and that has to be looked at. Of course, there may be other things, other joints may be involved. For example, rarely the temporomandibular joint may be involved, so that all these things are there. Rarely the lower back and the central spine may be involved. So these are rare things, but relatively less common. Also with this, one should also ask history of skin rashes as a general rule, which already we have talked about. And then we go on to examine the signs. And Dr. Pratibha has already mentioned the signs. There are a lot of signs in rheumatoid arthritis. If you examine the hands, there will be almost 4 or 5 different signs. The swan neck, the swan sign, and then the boutonniere sign, the Z deformity. So all these are there, which ideally one should know and try to elicit. Many times they may have fixed flexion deformities also in a late burnt out cases. But the important thing would be to elicit the active rheumatoid. That is the crux. So one should not just look, one should feel also. That is important. Feel the joints, try to elicit a bit of tenderness if it is there, see the swelling. So arthritis is different from arthralgia and pain. That is also just something that maybe for the postgraduates and the newcomers would be important. So thank you very much, Dr. Pratibha. I'll move on to the next question. I'll move on to Dr. Debraj. And Dr. Debraj, coming on to the next important disease, CTD disease, which is associated with ILD, and that is systemic sclerosis. Can you enumerate some common history points to be taken which point in favor of a systemic sclerosis? And also, what are the important clinical signs that we look for? And also, is systemic sclerosis different from scleroderma per se?
So going to the second part of your question, scleroderma is typically a Greek word which means the thickening of the skin. So when the scleroderma is only localized to the skin, then we will coin it as sinus scleroderma or scleroderma limited to the skin. And when it affects the internal organ, then we will label it as a systemic sclerosis. So this is the gross difference. Now coming to the symptoms and signs of systemic sclerosis, since it is like other autoimmune diseases, it affects almost all the organs of the body. So I'm just talking about the most important symptoms and signs. To start with the most important symptom, it is the thickening of the skin, which is very obvious from the nomenclature. So it typically affects the skin starting from the thickening. However, the first symptom may be Raynaud's phenomenon. That is which is very obvious in patients of the scleroderma. Second symptom is very typical when it affects the lung, like all other ILD patients, cough and shortness of breath. Third, because it typically affects the gastrointestinal tract, so the symptoms of reflux diseases are very important and which will help us also in suspecting systemic sclerosis in patients of ILD. So the typical reflux symptoms, constipation, as well as reflux leading to aspiration, pneumonia, and all those kind of things. It will also affect the cardiological and the neurological system, but not typical some cardiological systems, but in neurological carpal tunnel syndrome, again due to exuberant thickening of the skin and all those kind of things, and all other typical myalgia, arthralgia, these symptoms are present. Now, when we look for the signs, sir, the sign typically, first we will start from the fingernails, because we will typically use nail fold capillaroscopy to identify the telangiectasia of the vessels and all those kind of things. Second, we will examine the mouth opening, whether the patient is able to open the mouth and how many fingers we can push or we can enter through that open mouth. So this narrowing. Third of all, regarding it typically affects the eyelid skin. So while examining the pallor, whether we will able to see the or retract the eyelid as other patients or not. Other important signs are typically when it involves the respiratory system, like all other ILD patient, typical velco crepitation and also presence of the clubbing. Although classical, it is present in RA-ILD, still in systemic sclerosis, we may find clubbing in late manifestation of the disease. And other typical signs are based on depending upon the involvement of different organs, sir.
Okay. Yeah. Thank you, Dr. Debraj. I think again, so systemic sclerosis has got some typical symptoms that one has to ask. For example, that one would probably not get in other CTDs. For example, the esophageal dysmotility related symptom is something which is more classically seen in a scleroderma patient, maybe not in others. But of course, we have to ask it. We have to ask it because we don't know the diagnosis upfront. We have to ask it for all patients. And then after we take the entire history, we then join together everything to find out which is the most likely CTD. And of course, some specific signs you have enumerated. The digital, sometimes, in long standing cases you may get erosion of the digits, so digital ulcers, digital gangrene, all these things are also. So that is why when you see a patient in CTD, somehow the hands give a lot of information. There is so much that you can see in the hands. So it is very important to examine the hands, palms, everything very, very carefully. Even if you remember in dermatomyositis, you will see many features over there. You will see the cauterized papules, all these things. So somehow the hands are very important for CTDs, and one should see that very, very carefully. And the second important thing would be the eyes and history of eyes, uveitis, iritis, any history of redness in the past or any point of time. Many times we forget to ask all these things, but I think that is as important as part of the history that we can do. So moving on, I think I'll move on to Dr. Deepak now. Dr. Deepak, we come on to the next important CTD, which is the SLE. Now, in SLE, again, can you enumerate the common clinical features, the common symptoms that the patient will be telling us about? What should be asked, and what a little bit about what is acute lupus pneumonitis? How do we differentiate this acute part from an infective pneumonia? That is also sometimes a little bit of a concern.
Right. First of all, thank you that this SLE is a multisystemic disorder, but still, as rightly mentioned by the earlier faculty also, that asking about history of visit to a dermatologist will really give you an answer. Patient normally presents with malar rash, photosensitivity. Now, these patients also have musculoskeletal disturbances, like they have arthritis, arthralgia, and they have myalgias. These patients also have other system disorders. Like they also can present with dryness of eyes, as you rightly mentioned earlier, that they might have eye symptoms. Then again, they come with or may have oral ulcers. Then they might have features suggestive of gastrointestinal disturbances, like they might have esophagitis, or they have abdominal pain, which can be lupus pancreatitis or peritonitis. Then cardiac involvement and respiratory involvement is also there. So mostly, since it's a multisystemic disorder, we need to evaluate symptoms for each one of the system. Mostly we see patients that most evident signs and symptoms are your skin changes, malar rash, oral ulcers, which we look for, and photosensitivity. Regarding the next part of your question, sir, it is very important. If a patient is already diagnosed with SLE, then it is very difficult to diagnose to differentiate between acute lupus pneumonitis and the infective, because patients are already on the immunosuppressive agents. So, in these certain tests such as biofire, microbiological analysis, bronchial lavages, these help in differentiating the organism, whether it is infective or non-infective. Other blood tests can also help in differentiating. They are not very specific, but still serum procalcitonin and the parameters can help us differentiate between these two. But as rightly mentioned, it is very important to differentiate between these two because treatment modality is totally different in both of them.
Yeah, thank you very much. Yeah, thank you, Deepak. So I'll basically SLE is also something. It's a multi-system disorder, like you said. And if we find an acute form, if we find acute patches coming, acute ILD pattern coming, then we have to think of again infective etiology. Like for example, even viruses, we have to think of acute viral etiologies. We have to think of DAH. We have to think of other type of ILDs which are more rapidly progressive. In this situation, probably a bar, like you said, might be useful. So the cell count and all these things would be pretty useful in this kind of a situation. Yeah, that's correct. Because on one side you'll be treating with antibiotics, on the other side you'll be treating with probably higher dose of steroid. So it is important to differentiate between these two conditions. So okay, we'll move on now, and we'll move on to Dr. Praveen. Dr. Praveen, you touched upon in your presentation upon myopathies also. So can you elaborate a little bit about idiopathic inflammatory myopathy? So that is one pattern of myopathy so myopathic disorders are also being increasingly recognized as a cause of ILD. Now with the advent of the ENA profile, we are getting more MDA5 antibodies and all these things which are very specific of myopathies. So we are
Yes.
recognizing more. What are idiopathic inflammatory myopathies and how do we diagnose them?
So, idiopathic inflammatory myositis are basically myopathy means basically there's a skeletal muscle inflammation. So it's a heterogeneous group of these sort of connective tissue disorders. And the base thing is a skeletal muscle inflammation. So there are different types of idiopathic inflammatory myositis, of which we all would have heard of the dermatomyositis, the polymyositis. The other ones like inclusion body myositis. And there's a different types of the dermatomyositis, which is like an amyopathic dermatomyositis, in which there is no myopathy associated with that. There is juvenile diabetic myositis, anti-synthetase syndrome, etc., etc. So these are a group of disorders which has generally a lung involvement, cardiac involvement. There will be joint pains and skin involvement generally. So and this has a strong genetic background. Usually, these patients will have classical diagnosis is based on before that the clinical features. So the classical clinical feature is basically these patients present with a proximal symmetrical muscle weakness, along with small joint pain and the stiffness which is associated with that. They can have other things like, for example, I have mentioned in my case, can have Groton's papules, which is seen on the extensor surface papules on the hands. Then they can have other cutaneous vascular manifestations that we see, like, for example, a violaceous lesion that is seen over the skin, like a shawl sign, then digital fissuring of the fissuring of the digits, like a mechanic's hand, etc., etc. So these are the variety of clinical features that we generally see in that. To diagnose it, of course, if we need to have the blood biomarkers, especially as Dr. Anant Mohan sir has already mentioned. We need to do as more and more the myositis profile panels we are doing. We are coming out with more and more, finding out more anti-synthetase antibodies and patients with anti-synthetase antibodies. Similarly, anti-MDA5, which is associated with a very poor prognosis, the PMSEL, anti-RO, anti-WHO, etc., etc. So these are a variety of the autoantibodies that we generally see in this. And in fact, in lung, it presents with a very subtle or an asymptomatic ILD to an very fatal form of ILD in which whatever we do, we may not give the patient back. That sort of very dangerous ARDS. That's something that we can see in the lungs. Then, if you don't have any of these, then the gold standard for an inflammatory myopathy is ideally a muscle biopsy.
Correct. Yeah. So I think again, myopathy is something that is being recognized more and more with more biomarkers and antibodies coming up. At the same time, the traditionally the proximal muscle weakness and the lack of reflexes and all these things, the bedside teaching which was there goes hand in hand with this. Compatible symptoms also goes hand in hand. And muscle biopsy nowadays it is much less done because we have other things to corroborate. But if required, yes, then there used to be elevation of the CPK to thousands, in acute polymyositis. So these are all kind of corroborative investigation that can be done. Okay, so we'll move on now to another CTD type kind of thing, and I'll again come back to Dr. Amita for that. So, Dr. Amita, there was a mention of IPAF in the previous lectures. So, can you tell us something about IPAF? It is somewhat of a gray area. It is not something well characterized. So, when should we suspect an IPAF?
Right. As Bhavin mentioned in his lecture, and Dr. Praveen also made a mention of it, the interstitial pneumonia with autoimmune features. This terminology, I think, was used a decade ago in 2015, where, if one has to explain, when you have a definite diagnosis of connective tissue disorder, these disorders are specifically defined, and the patient comes and gets diagnosed as ILD, things are simple. But when you have an interstitial lung disease, and then you look at the patient, you have certain features where you clinically suspect, then you go ahead with a CT scan where Bhavin mentioned certain specific signs where he also would say that there are chances that this is likely to be CTD ILD, but then when you do an autoimmune profile, your results are negative. So that is where now, in the last decade, the research terminology, which was coined in 2015, has gained to the level, it has reached a level of classification. And there have been three domains which have been described, which are the clinical domains. Then I think Praveen mentioned that in the lecture, the morphological and the radiological aspects. So, as Dr. Anand Mohan, you mentioned, probably hands are the ones which take the forefront of the clinical domain, where it is the mechanical hand, then your proximal ulcers. You have a list of things which are described for terminology of IPAF in clinical diagnosis. Then you have a serological domain. So in an institute, in our tertiary care institutes, it's not difficult to get all of the serological types which you suspect. But then the basic ones at least should be available in the form of ANA analysis, where a titer of more than 1 in 320, if you have it for diffuse, speckled, or homogeneous, or any titer which is there for the nucleolar patterns or the centromere patterns, is all right for getting the serological domain positive. And lastly, you have then you have a list of markers where you have Rho, La, anti-Smith, name it, and it will be there according to the CTD definitions. And then lastly, you have the morphological domain, which will include the HRCT features in places where you have the histopathology, which is not very common nowadays, because probably the biopsies we really don't need to do with the other features being available. And as it was mentioned in the lecture, the multi-component. So involvement of the pleura and the airway is again a part of where you should suspect IPAF. So if you have amongst these three domains, any two positive, then your likelihood of IPAF being there is there, if I can make it clear. These are, I think Dr. Praveen has already shown a slide where he has shown the classification. So it is an interesting concept where you are not sure about the diagnosis of CTD, but nonetheless the features are there. One must suspect that. Thank you.
Yeah. So ultimately, it is something. It is an entity where one cannot fit in a patient's profile into a definitive CTD. You do a full workup, but you're not coming to a diagnosis. He's not filling the criteria, but you have some criteria. Then you are not there fully. So then that is probably what is termed as an IPAF. So now I don't know what. So my take on this is, in the last, I wonder if it is being overused. Because sometimes we are trying to make it as a dustbin diagnosis. So without trying to get into the depth of a patient and work up to try and find out the exact cause, we tend to label a person as IPAF and say that, okay, he's got no typical signs of CTD, but he has got an ILD because we are a respiratory department. We will come get a CT scan of ILD, but then we don't know which CTD is causing that ILD. And we end up labeling and we get an ANA positive, we end up labeling the patient as IPAF. Now, I wonder how right that is and whether we should make more efforts to try and diagnose. But yes, if I can draw an analogy with lung cancer. Now, lung cancer, there is an entity called non-small cell lung cancer, NOS, not otherwise specified. So that is something where we don't know, it is neither squamous, it is neither adeno. So similarly, probably this is something similar. Anyway, so again,
There's
an
a
interesting concept.
multidisciplinary approach, probably, which is the last thing they're trying to get in the rheumatologist, which should be involved
Yeah,
in the final.
yeah.
Yes. So, yeah, what you said is right. Yeah.
Yeah, sure. So, okay, I'll move on and I'll move on now to Dr. Pratibha. So, Dr. Pratibha, now moving on from specific CTDs to ILDs per se, what are the common ILDs? Although this has been touched upon by the lectures, but I
Yeah,
think it is always
exactly.
better to what are the common ILD patterns which are usually a part of the CTD ILD and which is the commonest one in RA and systemic sclerosis?
Of all the CTDs, RA is the commonest. Systemic sclerosis follows it, or almost we see lots of it. So in RA, more than 50% present with UIP pattern and followed by NSIP pattern. So for the benefit of our younger colleagues, so still in RA, UIP is the commonest form of CT findings you will find, followed by NSIP. There are few uncommon CT features in RAILD, like lymphocytic interstitial pneumonia pattern. I have seen it very less commonly. It has various cysts, and it is very non-specific to be associated with RAILD, but it can be one of the patterns. Then organizing pneumonia it is more common than LIP pattern. And sometimes the pattern is very non-specific in the terms of centrilobular nodules, which you sometimes confuse with HP also, but which is also not very commonly seen. So the most common pattern with RA is UIP followed by NSIP, and rare forms contain OP, LIP, and some nodular opacities. Now we come to systemic sclerosis. Systemic sclerosis does not, most of the patients has NSIP pattern. And I hope our youngsters know how to differentiate between uh, firm UIP, probable UIP, possible UIP, and then NSIP. So in NSIP pattern, we need to look for pleural sparing. Our opacities are slightly away from the pleura, and the apico-basal gradient is disrupted. It is not so well maintained as it is seen in UIP pattern. So systemic sclerosis, NSIP pattern is the most common pattern, followed by other pattern which I have mentioned for RA as well.
Okay, thank you, Dr. Pratibha. So, and also I think you mentioned earlier that many times ILD may precede the RA, development of
Right.
RA also. So that doesn't always necessarily mean that it happens in the first RA and then ILD. So we have to be mindful of that as well. So these are the common ILDs again for the benefit of postgraduates. Again, a favorite type of a Viva question, which
Right.
are the common ILDs in this particular CTD, which is the common ILD in that particular CTD. So one should know that and also apply to clinical practice. Although the variations may exist, overlaps may also exist. So we move on now to Dr. Debraj once again. Dr. Debraj, can you enumerate the few common HRCT signs of a CTD ILD? This also has been covered earlier, but I think this is important to just tell the important CTD ILD HRCT signs.
As you rightly pointed out, sir, this has been elaborated in detail by Jankharia sir's presentation. Still, I am recapitulating it. So, the number one is the when we will suspect CTD while we diagnose the patient having ILD. So, first is exuberant honeycombing. So, if we see the honeycombing is much exuberant comparison to the clinical presentation, so then probably it is due to rheumatoid arthritis associated. Second one related to the honeycombing is that usually in patients of IPA, we see the honeycombing in the posterior portion. So if the honeycombing involves the anterior portion of the lung, that is very specific for CTD associated ILD, what we used to call as anterior edge sign. Third one is that if we see presence of straight edge sign, that is particularly in patients of systemic sclerosis ILD, when we look at the sagittal section, there will be a clear demarcation between the involved lung and the non-involved lung, which is typically absent in other other ILDs. We cannot clearly differentiate. The portion of the lung which is not involved by honeycombing is usually having some kind of ground glassing or some kind of reticulation. Other signs are that island of reticulation sign. That means that there will be a specific island of reticulation, which may be a subpleural reticulation. Other portions of the lung are spared. And that island of reticulation, when involve four corners of the lung, that we used to call it four corner sign. That is the antero-superior and the posterior-superior. Typically, again, we used to label it when we look at the sagittal section of the lung. Other associated findings such as esophageal dilatation, if you see a large esophagus while looking at the CT scan, then probably this is a patient of systemic sclerosis ILD. Also, presence of the cyst are much more in CTD ILDs, even in absence of honeycombing. So just presence of too much many number of cysts also, but the difference is that just presence of cyst will not label it. There has to be presence of the interstitial lung disease. So these are the radiological signs which we look for. But again, if you ask me, sir, you will probably also agree the anterior edge sign, that is the anterior involvement of the honeycombing. Second one is the straight sign, which probably we tend to look much more in number compared to other signs in day-to-day our OPD practice.
Yeah. I think that's correct. So one needs to know these typical signs and typical situations. Although we will obviously not get all the signs in every situation, and also we must know that which sign is more specific and which sign is less specific for a particular disease. For example, you talked about the straight edge sign more commonly seen in systemic sclerosis ILD. So all these caveats are there, but it is again important, a important viva question type of thing. You know that which type of sign is more commonly seen in which type of CTD. So it's good to remember these. And with this, we move on to the next question, and I'll ask that to Dr. Deepak. So, Dr. Deepak, again, a very specific question. What are these ANA and ANA blot antibodies, and what are the myopathic specific autoantibodies? So this, and then second part, in a patient with suspected CTD, what are those common blood tests that you would order?
Right. Sir, I'll start with the second part of the question. That once I have suspected ILD patient or I have a confirmed ILD patient and I have suspected CTD. So according to clinical feature, I will do the tests. Like if they have RA predominant features, I'll go with RA and anti-CCP. First, I'll do NA by IF, that is immunofluorescence, in which I will see the pattern which is present. After that, then if there is this is positive, then I'll go with ANA blot, which will tell me about the different type of antibodies which are there, like dsDNA or SM or MI2, these type of ANA blot antibodies which are there. And if I'm suspecting there is a myopathy, so I'll go with the myositis panel, which incorporates that 16 pattern from all MI2 till SCL100, PMSCL100, and MDA5 is one of the important in patients who have this rapidly progressive ILD. So according to the clinical features, I would like to segregate this patient because anyhow we are a resource limited country.
Okay, correct. So basically, earlier we used to have only rheumatoid factor and ANA and ANCA. But like I said, in the last 4 or 5 years, the auto antibodies have rapidly expanded actually, and that is why this the ANA blot. So basically, the ANA blot is nothing but it's that expanded version of the antibody profile. So the SSA, the SSB, the PM, the PL antibodies and the anti-Rho, anti-La, all these things are part of the gamut of the ANA. So basically, one does the antibodies depending upon the patient profile. Of course, in every patient, you may not need to do everything. Probably, I think Dr. Deepak, you would agree. In every patient, you would not like to do everything. It is not maybe not required.
Maybe not required, sir. It is all about the clinical features. First, history taking clinical features, then we advise the test according.
Correct. Okay. So that is one. So basically, we are now into the workup of the patient. So the patient is undergoing a battery of investigations. Dr. Praveen, after this part, what additional testing as part of investigation workup is required for a patient with suspected CTD ILD before we actually start the treatment? So I'm mostly talking about, say, blood-related testing apart from the antibody testing.
From the antibody testing part. So antibody testing part, or sir?
Apart from the antibody testing, yeah.
So I think apart from the antibody and the CT scan, probably one test that is really required is the lung function testing, the pulmonary function testing. So we need to do a full pulmonary function testing, that including we need to look at their FVC, we need to look at their TLC, total lung capacity, we need to look at their diffusion capacities, and so all these has to be looked into. So the FVC, the FV1 FVC ratio, the total lung capacity, and the DLCO. So in many a time of course in an early ILD, probably all these could be normal, but as the ILD progresses, we all know that these patients will slowly develop a reduced FVC and increased raised FV1 by FVC ratio, and worsened the total lung capacity and a worsened DLCO. So sometimes these patients, as I mentioned earlier, these patients can have, even though they have a significant lung involvement in CT, still sometimes if they have a coexisting emphysema, they still could have could have a normal FVC. But similarly, sometimes the DLCO FVC in some of these patients could have a markedly out of proportion DLCO, which means that there are some other pathologies also involved in that, as opposed to that of the FVC or the CT that we see. So in those patients, we need to actively look for signs of pulmonary hypertension or a severe emphysema. Then both can reduce the DLCO, which can give rise to an out of proportion DLCO. Similarly, sometimes the DLCO might be increased, as has been already mentioned previously, in case of an vasculitis, where there is a diffuse alveolar hemorrhage and the DLCO could be increased. So pulmonary function test is one thing that we need to do it before starting the treatment, and it has to be done on a follow-up basis also.
So would you advocate for, because we need the lung capacities also, so is a body plethysmography essential for all patients of ILD, because it is not available everywhere?
Yes. So at least the minimum thing that we require is an FVC. So that is the minimum then that we require. But it is always better to have a body box to give an accurate idea about the DLCO.
So I think when we are really diagnosing an ILD, it is always good to have the total lung volumes available. It may not be available at your center. Maybe get it done from some other center. Of course, it may not be required as a follow up, as a routine, but I think it's a good idea to have it at baseline. Secondly, one or two small things one might do if one has the facility to do a 6-minute walk test, and also at the same time try and measure exercise desaturation. Sometimes if possible, because these are some things which are early pointers towards hypoxemia. He may not be hypoxic at that point of time, but in early stages he may be hypoxic on kind of walking. Would you also advocate a baseline ECG in every patient?
Yes. So ambulatory walking testing and an ECG, and if possible an echocardiogram also. Yeah. But ECG is a must.
So I think these basic general things might be required. And before we start the treatment, the general profile of the blood sugar, LFT, RFT, because we may end up giving steroids. So obviously we want to know what is the state of the sugars and everything at that point of time. Fine.
And if the
Okay.
patient is sick, then probably infectious biomarkers also before
Infectious
starting
biomarker. So
something.
depending upon the patient profile, correct. So I'll move on now, and now coming on to the treatment part. So we have done the workup part, and now we have to start some kind of a treatment. So we'll take the treatment disease wise specifically, and I'll start with Dr. Amita now. Dr. Amita, what? So you have an RA-ILD, and he's got a cellular ILD kind of a pattern. So or maybe you have got different scenarios. One may have cellular, one may have non-cellular or fibrotic, and another might be having a UIP pattern, which you're saying is the commonest pattern of RA. What initial treatment would you start for these situations?
Right. So when they come to us, being in a multidisciplinary center, they usually are on treatment with disease-modifying agents, which may even now include methotrexate. Earlier on, we thought methotrexate was not okay for us with the drug-induced side effects, but now it has been seen that methotrexate may delay the start of ILD in rheumatoid. So we don't omit that. But then a number of them still are on azathioprine, and if they are tolerating it and the ILD is stable, we still continue them on azathioprine. When they come in exacerbation with RA-ILD, we use steroids, which might be in the form of injectable, which is a short course. And once they improve, then one really thinks whether one needs to change the molecule in case there is a decline. Then mycophenolate is now freely available, and mycophenolate we have been using, I think, in the last 5 years. Otherwise, it used to be azathioprine, all right. We rarely require to use cyclophosphamide in rheumatoid. Regarding rituximab, the rheumatology at times has been using that once we eliminate the risk of tuberculosis. But nonetheless, in a few patients in whom rituximab was used, we have had them coming back with tuberculosis, which might have been latent and they have manifested with the frank infection. So I would say MMF, mycophenolate mofetil is the thing. Apart from that, an antifibrotic, as whenever we see a fibrotic pattern, we are using perfenadone in rheumatoid arthritis. I think we have evidence for nintedanib also. So either of the two, depending on the tolerance of the patient. So since we don't have the randomized trials, which would tell us that this only, we still use our clinical discretion and the side effect profile mainly. Those who tolerate whichever molecule, we still give them that in consultation with rheumatology. Thank you.
Right. Okay. So I think we'll just talk a little bit more about the methotrexate part, and I'll ask Dr. Pratibha about that, because I think Dr. Amita has already told us. Okay, we give steroids, we give the methotrexate is being used again. Otherwise, we use the mycophenolate. We can use even azathioprine, rituximab after eliminating the risk of tuberculosis. But earlier it was said that methotrexate can cause ILD itself. So what is the current state, and is there any way to differentiate a methotrexate-induced lung injury versus an ILD progression on a person who's on methotrexate? Is there any way to differentiate?
It's a very interesting aspect. I've been using methotrexate for long. It is one of my favorite drugs in various scenarios, including sarcoidosis. And all of these diseases cause lung fibrosis per se, or has a potential for lung fibrosis. With initial hitch, and after reviewing lots of articles and literature, the incidence of toxicity with methotrexate is 30%, but that's not lung toxicity. That includes bone marrow suppression or liver toxicity. But lung incidence of lung toxicity in that form of fibrosis is only 1%. So methotrexate is a relatively safe drug, even used for RA and RA-ILD. So after gaining such confidence, methotrexate can be used in RA-ILD. It can be monitored. In my past 15 years of practice, I have seen one case of methotrexate-induced fibrosis in a case of RA-ILD, and we proved it by doing a lung biopsy. and finding typical features of drug induced lung toxicity, which include alveolar cellular infiltrations, peribronchial thickening, and presence of granulomas into the lung interstitium. So these features are different from typical UIP histopathology. But before embarking upon a histopathological diagnosis, the suspicion is important that patient after starting methotrexate is showing deterioration in her clinical symptoms in form of respiratory distress, is sometimes develop fever, which is a part of drug toxicity, rapid decline in FVC and FEV1, or rapid decline in the lung functions. So these features, when patient develop, we should keep methotrexate toxicity as a differential, and I am able to prove it in one case where we could do a biopsy that it was associated to the drug, not to the disease.
Right. So I think again the only important message here is that contrary to what was taught about 10-15 years back, methotrexate right now is not considered to be a dangerous drug for the lungs as far as treatment of ILD is concerned. So I think that if we just drive this point home, I think it would be reasonably okay. So
Yeah.
we'll move on quickly, and I think in the interest of time, again we'll just try and cover the rest of the parts. Dr. Deepak, I'll come to you now. Uh, Before that, I think, I think the Dr. Debraj, since we are going in sequence, now we are coming to systemic sclerosis. As systemic sclerosis associated ILD, what would be your preferred treatment choice? And especially when to give steroid, when not to give steroid?
Sir, just right now, recently, it has been published by Dr. Ganesh Togu and the group of researchers that the guideline of systemic sclerosis associated ILD, what are the treatment options? So I will request every one of us, as well as all the delegates who are hearing patiently to us, to go to the ATS website and read the treatment of systemic sclerosis ILD. So first thing is that one is the strong recommendation. So which is the most favored drug is the mycophenolate mofetil based on the systemic sclerosis lung study 1 and 2. So MMF, they had a strong recommendation for use. Second is the conditional recommendation for the following agents. Number one is cyclophosphamide. And there is no difference between IV cyclophosphamide and oral cyclophosphamide. Third agent is that apart from cyclophosphamide and mycophenolate mofetil is the rituximab. So rituximab again can be used conditionally, and thereafter antifibrotic agents nintedanib and combination of nintedanib and mycophenolate mofetil. So these are can be used conditionally, and strong recommendation is for MMA. And more studies are required for use of parfenidone as well as combination of parfenidone and MMA. And regarding the question, sir, of whether which dose steroid should be used in the treatment of systemic sclerosis ILD, apart from the exacerbation of systemic sclerosis ILD, like all other acute exacerbation of ILD, steroid can be used. But otherwise, there is no recommendation for use of corticosteroid in systemic sclerosis ILD. Rather, they preclude the use of steroid in SSC ILD. As we all know, it increases the incidence of scleroderma renal crisis. And more typically, steroid probably is not beneficial, on the contrary, detrimental to the treatment of the systemic sclerosis ILD, and it actually increases the mortality. So,
Right.
we want to use only in acute exacerbation, like all other acute exacerbation, it has to be used. So, if we want to use, what is the drug of choice? MMF. If patient unable to tolerate MMF, then cyclophosphamide. And in antifibrotic, if we want to use, we should use nintedanib, because parfenidone in SSC ILD is still not advocated by the group of ATS publishers. What they have found, because there is no significant change in the lung
Right.
function
Okay.
as well as
Okay. Yeah. Okay. So I think the take home message from you is steroid should be used in very, very specific situations. The commonest drugs of choice in, because you see, most of the landmark trials have been done in systemic sclerosis associated ILD itself. And most of those results have been extrapolated to other ILDs. So the census trial and all that were showed, all have been done on scleroderma associated ILD. So MMF, cyclophosphamide, yes, you are saying is absolutely correct. I go beyond that to Dr. Deepak now. So just can you enumerate once more, again, one, two, three, the common order of priority of various immunosuppressant drugs for CTD ILDs and the second line. Suppose if somebody progresses on first line, what would be the important or the preferred second line choice? You are muted, Dr. Deepak. Yeah.
Yes. Sir, this question was rightly answered in ACR 2023 guidelines, where as we know, we have a battery of immunosuppressant agents, like ranging from mycophenolate mepryl, cyclophosphamide, rituximab, then methotrexate, then we have tocilizumab, then azathioprine. These are like first line agents. If patient progresses on that, as earlier mentioned by Dr. Praveen, also that we can use a switchover therapy or add-on therapy. So we can also use JAK inhibitors. Then we have calcineurin inhibitors, and also we have IVIG we can give in certain patients.
Yeah, thank you. So basically, is there any role of adding to immunosuppressants? Because otherwise we substitute, mostly we substitute. Is there any role of adding?
In certain subset of patient, when the patient is progressing, like we can add along with mycophenolate mepryl, we can add it with steroids, immunosuppressant.
Yeah, what I was trying to say, suppose say no steroids apart, can we add two other immunosuppressants along with that? Do we have adequate information about that? Because I'm not sure. We have only maybe one or two case series, but no guidelines to say that two immunosuppressants apart from steroid. So if any of the other panelists would want to add to that.
But occasionally, yeah.
Yeah, Dr. Pratibha?
No, I would say that if after we follow up these patients closely and after 3 or 4 months of single agent use, if the patient is still showing signs of progression, or we call it as progressive pulmonary fibrosis, there are indication and there are guidelines which suggest that we can add a second immunosuppressant to the existing regimen. And in the same scenario, we can add antifibrotics as well.
So what combination would you be preferring? Suppose somebody is getting MMF already, but he progresses. What would be the second one would add?
Along with steroids, sometimes we use biologics as a back to the wall situation. We use rituximab. We use in certain scenario, as Dr. Deepak has correctly mentioned, that we can use JAK1 inhibitors like tocilizumab, but the indications are selective for toci.
So that means if somebody, Dr. Dr. Praveen, you want to chip in?
No, as Dr. Pratibha has already mentioned, I think we can add on rituximab as a very good option, especially if the patient has a progressive disease on, say, patient already on MMF and the patient is not responding. Probably we can add on a rituximab and then taper down the MMF in that aspect, and then continue on a much lower dose of MMF or steroids, whatever they were on. So,
so basically, as a salvage therapy in a patient who's progressing in spite of maximum doses of immunosuppressant apart from steroids, then we may have an option of adding a rituximab kind of a preparation. Tocilizumab also can be added, but again, the risk-benefit ratio has to be very carefully weighed in this situation. Okay, so we'll move on and very quickly, Dr. Praveen, now I just continuing with you. So once you have started a patient on treatment, what would be your one or two tests for follow-up?
So it's to me, sir, right?
Yeah.
So for a patient, for a follow-up of these patients with an CTD ILD, we have now very clear-cut guidelines on that. That those patients they are followed up primarily with the lung function testing. So those patients who had a CTD ILD, these patients should undergo a regular spirometry, total lung capacity, and DLCO. So, and for a myositis, it's better to do it every 3 to 6 months, at least in the first 1 year, to see that they are not worsening, and then we can relax on that. For an systemic sclerosis, and again, every 3 to 6 months, every third or sixth month for the first 1 year, and then again we can relax on that. For an rheumatoid arthritis and Sjogren's and MCTD, 3 to 12 months, even
Yeah.
whenever the patient comes, and as feasible as possible. But and these patients can also be along with the same time, these patients should also undergo an either a 6-minute walk test or an ambulatory desaturation monitoring to see the progression. So if the
So
patient is unable
basically,
to do
we
it,
look at the yeah.
yeah,
Basically, we look at
exactly.
the lung functions. I think spirometry, DLCO, 6-minute walk test, and exercise desaturation would be the normal things. And then, of course, we can add on as per the condition and the symptoms of the patient. Fine. I think that again, take home message is pretty clear. So we move on to Dr. Amita now. Dr. Amita, you had done some kind of original research work on ILD also. Would you be able to tell very briefly about that? What exactly is yeah, you have to unmute, please.
It's an ongoing study, sir. With the support of Government of Maharashtra, we are doing it with ICMR. Dr. Pradhan is the co-investigator. It is the diagnostic and prognostic potential of immunological and molecular markers in ILDs. So, what we just discussed when you asked regarding whether we add another immunosuppressant. So, here we have interleukins, all 6 subtypes, and in some cases, in exacerbation, when we have seen it, the IL-6 is very, very high. So, whether these would be the candidates where one would choose tocilizumab is something for a clinician. Doing these markers together and having a matrix may help. It also has the genetic markers. I think a number of studies in our country have been done. Over 3,000 patients have been studied in one particular study. So we have an enrollment of right now 170, and amongst them we have about 42 who are CTD ILDs. And in them also, there are various patterns. I mean, if one has to talk about mutations, TERK mutations have been common, but not MUC5B, as it is actually described in rheumatoid arthritis. I think we have a year to go before we conclude and come up with the results, but essentially, it will probably give us a matrix in which we as clinicians can have some algorithm generated.
So
Thank you.
I think so. We'll wait for that to
Yes.
come up soon, and let's hope we get some insight and something new out of that. I'll have only one last question now. One last question to Dr. Pratibha, because then we'll take some audience questions. So, Dr. Pratibha, just quickly, what is the time when you would start an antifibrotic in a CTD ILD?
Yeah. I think in all of the CTILDs, antifibrotics place is yet not well defined. They are not to be used upfront except in systemic sclerosis. So first line treatment, nintedanib, as per the Senesis study, Dr. Praveen has clearly documented, has shown a beneficial effect in systemic sclerosis ILD. Apart from all other ILDs, whether they are rheumatoid, RA associated, mixed connective tissue disease associated, neither pirfenidone nor nintedanib has to be used upfront as first line treatment. They are to be used in cases of progressive pulmonary fibrosis or as a add-on therapy when we have already used maximum immunosuppressant or when we have exhausted all our other alternatives.
So I think that's again very important. Please do not use antifibrotics right, left, and center. I think whenever you are not getting an ILD person who's getting well, please apply the definition of PPF first. And
PPF, yes.
if that definition is being fulfilled in spite of your maximum immunosuppression, then maybe a trial of antifibrotics might be given. But that again, I think should be a collective decision of the unit. To my mind,
Right.
I feel it should not be just an individual decision, especially for somebody who is new into this. There is no shame in asking your seniors, asking people, because this is something which is really one expensive, it is slightly toxic, and we just don't want to give something to somebody just for the heck of it, just because it is available. Okay, I think now we'll kind of take up some audience questions. Before that, one last question I'll have again to I'll give it to Dr. Praveen. Dr. Praveen, last question: lung transplant. What is the time you would refer a patient, right time to refer a CTD ILD for lung transplant?
So typically, any patient who presenting with a respiratory failure, either due to the progression of the disease or due to the pulmonary associated pulmonary vascular diseases, can be a potential candidate for a transplant. In a patient, the classical the ISHLT guidelines are also clear that in those patients who has a reduction in FE1 of more than 10% or DLCO by 15%, or if there is a clinical worsening, even though the FEC is less than, the reduction is only 5%, but still has a clinical worsening or a progression of radiological disease over a period of say 1 to 2 years, then they are the ideal candidate for to be referred. Okay, along with if the patient is already on supplemental oxygen or at rest, or even when they have an exertion, we should tell the patient that it's the time that they should think about transplant. Probably they may not be the ideal time, but then they should think about that this patient and those who has a progression on the current anti-inflammatory therapy and ending upon and the need for an increasing oxygen, etc.
Yeah, I think it is best that the guideline. Everybody should read that guideline. There are clear-cut referral and listing criteria for COPD, for ILD, and for cystic fibrosis and others. So that should be read. It should neither be too late referral and neither should it be too early referral. But as early as possible, one should start the dialogue. Pratibha, you want to make a point? Quick point?
Yeah, after you, but the point is that it has been seen that in RAILD, transplant has not been, means most of them do good if you control the disease. Same as with systemic sclerosis. So the point is what you are saying, that it's the progressive fibrosis, pulmonary fibrosis, despite maximum medical therapy and 6 monthly or 4 monthly or 3 monthly follow-up to detect early deterioration. So not a patient who is not salvageable or who is on, 7 liters of oxygen, but a early referral.
Correct. So everything pointing at the right time. I think let's go quickly to the questions, and if somebody wants to volunteer with them, it's well and good. Otherwise, I have the liberty at this point of time to kind of bombard any of the panelists from my side. So I think that liberty I'll take, but we'll try and finish within 5 to 10 minutes. So one question, I think again, it's the first question was on lung transplant. So again, back to you, Praveen. What is the success rate of lung transplant in a CTD ILD patient? Just give us a range of figure.
Yeah, but generally the CTD ILD transplant rate is, success rates are pretty good, because the disease occurring in in a transplanted patient, the disease that recurs in a transplanted patient is also much less. It's probably the secondary infection that usually causes. So generally the post-transplant rates are fairly good, as good as, like, say, a patient who has undergone a transplant for an hypersensitivity pneumonitis. So usually around 30.
Yeah. I think the success rate will somewhere be around 1 year. 1 year survival would definitely be in experienced hands, should be more than 70 to 80% at least in experienced places. So I think that is one. So next would be, I'll direct this question to Dr. Debraj. When to use cyclophosphamide in a CTD ILD patient? What is there still any role? When can we use it? When should we use it?
Yes, sir. There is a role of cyclophosphamide, particularly in systemic sclerosis ILD. If the patient is intolerant to MMF, then it can be safely used as an alternative agent, and there is no difference of efficacy between MMF and cyclophosphamide. Only difference is regarding the side effect. So we need to be more cautious while using the cyclophosphamide. We should be aware of the side effect. In other types of CTD ILDs, like in dermatomyositis or idiopathic inflammatory myopathy, there is also role of cyclophosphamide. Not that much in RA associated, as we all know, it is not used that much. So in systemic sclerosis associated ILD or mixed connective tissue disease ILD or idiopathic inflammatory myopathy, there is role of cyclophosphamide, sir.
Okay. Thank you. So, Dr. Pranavi has asked, when do we give antifibrotics in CTD patients? I think that question has already been answered just now by Dr. Pratibha very clearly that when a person is kind of progressing on maximum immunosuppressants for an adequate period of time, and we have demonstrated using the definition that the person is having a progressive fibrosing ILD, that probably would be the time when you would be starting antifibrotics and not otherwise indiscriminately. Another question is there, and I would like to address this to maybe Dr. Deepak. How do you differentiate honeycombing from cyst? Actually, anybody can chip in over here. Anybody wants to volunteer. How to differentiate a honeycombing from a cyst? Anybody?
Multiple cysts aligned together is honeycombing. Cysts are actually single. They can be discrete. They can be present like in homogeneous. So accordingly, we have differentiated different types of cysts. Like in LAM, it is different. In LCH, it is different, and in UIP, it is honeycombing, which is multiple cysts which are at the subpleural space and which look like honeycomb.
Okay.
Sir, to add on to Dr. Deepak, sir, also honeycombing, the thickness of the wall of the cyst are more in compared to what is in the normal cyst, sir.
Yeah. So in a normal cyst, usually we take it as 3 mm or less than 3 mm or something like that.
Yes.
So 2 mm, 3 mm, less than that, thin walled. Yeah. Okay. So one question is coming again. Can we tell us what is the meaning? Can we tell what is the meaning of spatial and temporal homogeneity? I think that was talked about in Dr. Jankharia's CT scan lectures and all. So homogeneity. Dr. Amita, would you like to take that or anybody else? What is?
So temporal, where you have the normal and abnormal just adjacent to each other, that is the heterogeneity. These are statistical concepts which are applied in CT reading. So temporal homogeneity, where you have an area of fibrosis next to it, you have a normal lung area. And in pathology, when we see the differences, we have the spatial heterogeneity, different types of inflammation which is seen. That is what is probably it's mainly the temporal homogeneity that we see on a CT.
Okay. So, okay. Dr. Bharat from Gujarat is asking, as a pulmonologist, how can we manage CTD ILD in view of immunosuppression treatment? I think that also has been answered in a reasonably in detail. That if you have diagnosed a CTD ILD, depends upon what type of CTD it is. There are some, of course, steroids. If it is an active cellular type of NSIP pattern or something, then you will give steroid. Then you will add a second immunosuppressant if required, which may be either most often than not, it is going to be MMF. Most likely that is the in thing kind of thing. Otherwise, you can give cyclophosphamide. If required, you can go in for azathioprine. Otherwise, you can go in for rituximab, especially in a progressive situation. So I think this we have already covered. One question is there that a person is having ANA, Dr. Anant Kumar from Maharashtra, ANA positive but ANA blot negative, HRCT suggestive of a UIP pattern, how to approach? Dr. Praveen, would you like to take this? You talked about approach. So how to approach this now?
So ANA positivity is not just one thing that we need to look at it. We need to look at what type of positivity it is, whether it is what type of pattern it is, and how much positivity. So there is a usually say 1+ or a very low positivity doesn't mean anything. So unless we have an ANA positivity, which is say raise so and so, like something like a 1:160 or more, and with a specific, and we also need to look at what type of, whether it's a nuclear or a speckle pattern. And in that case, it's always better to send these patients for an ANA profile test. So if that is also negative, and if the HRCT is a UIP pattern, then probably we should take it as an IPF rather than a CTD ILD.
Okay. So next question coming from Dr. Arun from Jalandhar. I'll address this to Dr. Pratibha because she talked about antifibrotics. If a patient is intolerant to nintedanib, can we use pirfenidone in a systemic sclerosis ILD?
The evidence, as per evidence, should be used preferentially. But if patient is unable to tolerate it and you have proven benefit with antifibrotic, you can give a trial of pirfenidone as well. And after 3 months, you can reassess whether it's making a difference, whether it is stabilizing FVC or not.
Yeah. So again, these are all, the case-based scenarios. There, we cannot have guidelines for these. This a lot of this depends upon the clinical suspicion and our clinical judgment at this point of time. Okay. So the next question. Okay, this is slightly different. What is the drug of choice for CTD ILD associated pulmonary hypertension? Is there any drug of choice for this? Anybody would want to volunteer on that?
Sir,
Yeah, Dr. Pratibha, okay, and Dr. Debraj, yeah.
yes, sir. Sir, if you ask regarding the drug of choice, so probably we will prefer the endothelin receptor antagonist. So any one of the between ambrisentan is probably the most preferred. But usually we tend to use in combination with tadalafil and all those drugs. So it is basically the combination of two drugs. And when it is still not controlled, then we may think of adding the prostanoid analogs. But most, if we ask me the most preferred, it is probably the ambrisentan and those group of drugs, endothelin receptor antagonists.
Fine. Okay. I hope that answers your question. Next, I'll address this to Dr. Amita now. This one, coming from Dr. Bhavin Raja from Mumbai. Do you offer immunosuppression to CTD ILD patients who have got a well-controlled concomitant HIV infection? So basically, immunosuppression in an immunosuppressed patient, but reasonably well controlled.
Right. So based on the underlying condition, if immunosuppression is a must, in the sense if the CT is showing, maybe one would do a bronchoalveolar lavage in these patients. And if we see lymphocytic predominance, CT also showing ground glassing, and now at present we have the immunological markers, then yes, we may still advise with a good monitoring. I mean, depending on the type of immunosuppression one would choose, whether one will have the T and B lymphocytes, which are in a given patient, one would decide that rather than a hypothetical situation where one would. But if it is required, then yes, because the mechanism of immunosuppression will have to be chosen in a HIV infected individual, where you will also monitor the CD4 count and then not maybe choose the T and B cell suppressants and choose the other ones, which include the biologics probably.
Correct. I think so. This has to be done with a bit of care. You have to first, if you really need immunosuppression for ILD, then by all means it has to be given. At the same time, it has to be seen that the person's immune status does not deteriorate any further, and we have to make the right choice of the drug for that. So I think that goes without saying. The next two questions are based on myositis and myopathy. So I'll address that to Dr. Praveen because he talked about inflammatory myopathy some time back. So, Dr. Praveen, which muscle is preferred for a biopsy in myositis? That is one question. So, quick answer to that.
Usually the biopsies are taken from generally the deltoid or the biceps or the quadriceps muscle. Usually multiple biopsies are taken from that. That's a general.
Okay. The other one is, what is the risk of ILD recurring in an MDA5 positive dermatomyositis after a lung transplant?
After lung transplant. So generally the recurrence rate, as I mentioned earlier also, that the general recurrence rate of the connective tissue disease in a post-transplanted patient is very, very less. In fact, there are only very few case reports which said that there has been some amount of there has been some very few case reports of recurrence of the same thing in a lung transplant. And in fact, as far as I know, I have not seen any studies which have shown that there is a recurrence of this MDA5 positivity in any of in a transplanted patient.
Correct. Okay, so we'll move on now. I think next couple of questions have already been discussed 2 or 3 times. One is how to diagnose interstitial pneumonia with autoimmune features. IPAP has already been discussed 2 or 3 times. that is based upon the conglomeration of some clinical, the morphological and serological parameters. So that criteria was already elaborated, and there is a good review article on that as well. Next is, which immunosuppressant would you prefer the most for CTD-ILD? I think again that has been talked about. Depending upon the CTD, we will decide which immunosuppressant. More often than not, it is likely to be, apart from steroid, it is likely to be the mycophenolate as of now, right? So the next question was when to start antifibrotics. We have already talked about that. Criteria for diagnosing RA and acute lupus nephritis. I think that also we have discussed, how to differentiate it from acute infectious pneumonia. So basically, I think we'll skip this one. What is the most common ILD in RA and systemic sclerosis? Again, as we talked, in RA, it is the UIP. In systemic sclerosis, more likely to be the NSIP pattern. When to suspect CTD in patients of ILD with no systemic symptoms? Should methotrexate be considered as an initial therapy in RA-ILD? So methotrexate in RA-ILD, I think Dr. Pratibha, you had also talked about that. Would you like to quickly talk about this one? Methotrexate as initial treatment in RA-ILD. Yeah, Dr. Pratibha, can you hear?
Yeah, sir. Tell me, sir.
So the question was, can we consider methotrexate as initial treatment in RA-ILD?
Yes, we can consider and monitor the patient. So steroid should be the upfront therapy in RAILD. Along with, we have several disease modifying agent option in RA, and methotrexate is one of them. And we can, under close observation, we can use methotrexate upfront in RAILD.
Right.
Though the recommendation says that methotrexate, Lefra, and TNF alpha should be used second line, but our experience and as per the literature, we can use it in case we want to use it.
Right. So the next question was also actually answered once. What are the other immunosuppressives of CTD-ILD? I think we have talked about it. Mycophenolate, then azathioprine, tocilizumab can be given, rituximab can be given, and then there are the JAK inhibitors, etc. So we have gone through that. Cyclophosphamide also we have gone through it in case of CTD-ILD. Comparison of cyclophosphamide versus rituximab, I'm not sure if directly has been done. Dr. Debraj or anybody, any idea? I'm not aware of this.
Whatever little I went through, usually the comparison is between the MMF and the cyclophosphamide.
Yeah.
And rituximab is mostly in those patients who failed, but MMF versus rituximab is there, sir. I didn't find, but there will be studies, sir, with comparison of cyclophosphamide versus rituximab.
Correct. So next question, what are the lab investigations to be done for a suspected CTD-ILD? I think already that Dr. Deepak and Dr. Praveen had already mentioned, apart from the full ENA profile, not full, but wherever required. First, we do the basic profile. If required, we do the detailed profile. And then apart from that, we look at all the other LFT, RFT, as well as the sugar part, because we'll have to give steroids at some point of time. Dose of MMF and how to proceed with this. I would say, just to save time, if I can just answer that, I think ideally one who wants to have a target of 1.5 to 2 grams per day. So one may start a little lower dose, say 500 BD or something, see the tolerability, make it 750 BD if required, otherwise go straight for up to 1 gram BD. This is in a normal weight adult patient. So is that okay? Anybody wants to make a comment on that, or is it okay? All right. In acute exacerbation of systemic sclerosis, ILD, what to use if not steroids? So this question, Dr. Deepak, would you like to take up, or anybody else after that? In acute exacerbation of SSC ILD, if not steroids, what else can be done?
Sir, if the patient is having acute exacerbation, we can have other options like we can have IVIG, and we can also give patient IV cyclophosphamide. These are the two options which can be used for SSILD exacerbations other than steroids.
Correct. Okay. I think that's fine. Last question, I think I'd give to Dr. Amita now. Are there any concerns about using nintedanib in PPF along with mycophenolate? Again, an interesting combination. Progressing pulmonary fibrosis on mycophenolate, can we add nintedanib to it? Any concerns?
Uh,
The to-
Yeah,
the
Dr. Amita
tolerance,
first and
yeah,
then Dr. Debraj maybe after that.
the tolerance of it, I think, is very, very important with nintedanib. What we have seen is at times it is not tolerated in our set of patients. So we don't use it very, very commonly in fibrotic ILDs. If one has shown a deterioration, we attempt starting it. But then, if there is a lot of side effects, we discontinue that so many times. That has been the actual real life experience. There are a lot of GI side effects which have been common in a set of patients who come to KEM. So that's the thing.
Correct. Okay. I think we have even covered all the questions that we had in the chat box. And as you can see, we are past 10:30. I
Can I
think,
just
yeah, Dr.
add
Praveen, you
on
want to
one?
make one quick point? Yeah.
Just one point regarding that previous thing that in acute exacerbation of SSC-ILD, what to use if not steroids? I didn't exactly understand why he asked like that. That it's not that when the patient is acutely sick, you cannot use steroids in a patient who has an acute exacerbation of SSC-ILD. You can definitely use a steroid, but over and above, as Dr. Deepak has said, we can add on the other drugs. It's in a stable patient or in a patient who is progressing on that, it's not to use a steroid. That is a long-term steroids.
Yeah, so basically, I don't think there is any real contraindication to using steroids in an
Thank
acutely
you.
ill patient. It is actually a life-saving therapy at this point of time. So, point well taken. Now, quickly, I would ask our panelists to give just half a minute, last minute message, any take-home point that they would like to give on any aspect of CTD ILDs. We'll start with Dr. Amita.
I think CTD-ILDs, when diagnosed early, are very rewarding to treat, where we look at the CTD component also and the interstitial component also, where the monitoring guidelines one follows. I think the prognosis is far better than the as compared to our idiopathic ILDs.
Thank you. Dr. Praveen.
Uh, Clinical examination and history taking is the key. And as Anand Mohan sir has said, looking at the hands is extremely rewarding if you're thinking a patient in terms of an CTD-ILD.
There's one area when looking at the hands can be really medically rewarding, and nobody will criticize you for that.
Oh, yes.
Okay, Dr. Pratibha.
I'm sorry, but Anushka, I'm sorry. Uh, I'm sorry, but I lost the.
No, nothing. We're just asking for any last 1 minute take-home message you would like to give to the audience regarding CTD-ILD, any part of
Okay.
it.
Okay. I think it's a part of our ILD workup to think about connective tissue disease because that changes the prognosis and the treatment strategy. So while we are, dealing with the patient of ILD, we should make a mental note of whether connective tissue diseases are a possibility or not. So that's I would like to say.
Thank you. Dr. Debraj.
Sir, first, we should not label every CTD ILD where we are unable to diagnose which type of CTD as IPF, as you rightly pointed out. So we should use the term IPF very cautiously. We should label out other specific CTDs before labeling the term IPF. And second is we should not use steroid indiscriminately while we label this as CTD ILD. We do not use nowadays steroid that much in IPF or that kind of fibrotic lung diseases. But once we have a diagnosis of CTD related thing, we tend to overuse steroid. So that should be my message.
Okay, thank you. Lastly, Dr. Deepak.
Yeah. So managing CTD ILD is not a one-man show. Always try to seek help of your rheumatologist. Have a MDD because many a times what our eyes don't see, the rheumatologist eyes see. These things should be take home as we start our practice at a earlier as an early career member. Always try to seek help from a rheumatologist friend whenever it is a CTD ILD.
I think, yes, absolutely. Very important point. It's a teamwork, just like there is an MDT in lung cancer, there's an MDT in ILD. In fact, there can be a collaboration in so many diseases because in spite of knowing so much, still there is so much we don't know. That is true. So with this, I think I thank all the panelists, all the speakers. I think we had a fantastic session. I hope we were able to cover most of the important points related to CTD ILD, which are practically important and which may be of
Nora,
interest to everybody else also. With that, I think I'll thank again the organizers, the Indian Chess Society, and everybody, and to the academic sponsors for having this wonderful webinar. Thank you, lastly, to all the people who have logged in. Again, I think more than 1,500 or 1,700 logins have been there. What I'm told, and that is really extremely gratifying, and it just shows that everybody's interested, and also that the panelists and all the speakers and faculty really kind of did a great job. So thank you very much once again, and good night. And I'll hand over back to the organizers.
Thank you, sir.
Thank
And
you.
thank you,
Thank you.
Thank
ICS.
you. Thank
Bye.
you,
Good night.
everybody. You
Thank you all. Good